I will be talking about Empagliflozin and Linagliptin combination with the Emperor-reduced trial data. And I am Dr. Gaurab Bhaduri. I am a consultant in the Department of Diabetes and Endocrinology at Medical Super Specialty Hospital, Kolkata, and associated also with Apollo Sugar. So today we'll be talking about a very important topic of SGLT2 inhibitors and DPP4 inhibitor, and how together in combination they can be very useful in the treatment of type 2 diabetes. And we'll also look very close look at the Emperor-reduced trial, and we'll see how this trial is now changing the entire landscape in the treatment of type 2 diabetes and patients with cardiovascular disease. So there is a very complex interplay of cardiovascular disease and type 2 diabetes, and diabetes confers a threefold higher risk for fatal CV event. And this is extremely important when we take this factor into our account while treating patients with type 2 diabetes. Now, CVD accounts for every 2 out of every 3 deaths in patients with type 2 diabetes. And we know there are traditional risk factors like tobacco use, advanced age, hypercholesterolemia, hypertension, which will augment this CVD risk in these patients. Atherosclerosis occurs nearly 14.6, around 15 years earlier in the presence of type 2 diabetes. So type 2 diabetes itself is atherogenic. And incidence of heart failure increases from 8% to 36% with every 1% increase in HbA1c. So that's a very sharp increase from 8 to 36% with every 1% increase in HbA1c. Now, even though the risk of heart failure increases with poor control, such risks are not adequately reduced by intensive management of diabetes. So very good glycemic control will not only reduce this extreme high risk. So what we can do to reduce this risk will be the next part of our discussion. Now, the initial presentation of CV disease with type 2 diabetes and no history of cardiovascular disease. So those patients who do not have any history of cardiovascular disease has been with diabetes. Initial presentation these patients come up with. Now, this is the Caliber program, and it evaluated a lot of patients, out of which 6,137 patients were diabetic, and the median follow-up years was 5.5 years. And they found out that in patients who had diabetes, the peripheral arterial disease was the first presentation in 16.2% of the patients. That was the highest, and it was very closely followed with heart failure being the first presentation in around 14.1% of the patients. So very high incidence of peripheral arterial disease and heart failure as initial presentations in those patients who previously did not have any history of cardiovascular disease in the type 2 diabetic population. Now we have understood that there is a very strong relationship between heart failure and diabetes. Now, if we look at other data, we will see that people with diabetes have a 2 to 5-fold higher risk of developing hypertension. And that is independent of whether they have a ischemic heart disease or hypertension. Now, diabetes confers a 60 to 80% greater probability of CV death and all-cause mortality in those with established heart failure. So not only diabetic patients are at a very increased risk of developing heart failure, if they develop heart failure, then there is a very, very high risk of all-cause mortality as well as cardiovascular death. Now, greater than 20% of patients with diabetes are diagnosed with heart failure, and this entails a substantial morbidity and mortality. And we have our data to tell you that. And the most common etiology of heart failure in diabetes include coronary artery disease, hypertension, and diabetic cardiomyopathy. So these are the prime factors which actually causes heart failure in the type 2 diabetes patients. Now, as we have understood that heart failure is a common occurrence in patients with diabetes, we also need to understand the reverse is also true. So diabetes among patients with heart failure, and if we look at the different data, we have patients heart failure with preserved ejection fraction, heart failure with the reduced ejection fraction, and overall. So the prevalence of diabetes in heart failure is around 25 to 30%. That means that 30% of patients with heart failure will also have diabetes. And in around 40 to 45% in those patients who are hospitalized for heart failure. So the numbers are even higher for those patients who require hospitalization for heart failure. So there's a very strong correlation between the two. Now, diabetes can lead to heart failure through both atherosclerotic mediated and atherosclerotic independent mechanisms. Now, patients with type 2 diabetes are at a risk for atherosclerotic events like myocardial infarction, which obviously results in heart failure due to reduced ejection fraction due to myocardial wall damage. So because of the impaired pumping function, so there is the chance or increased incidence of heart failure in this group of patients. But also patients with type 2 diabetes are also at a risk of heart failure due to indirect inflammatory and microvascular effects on the myocardium. So a lot of other things also play a role in the development of heart failure in the patients who have type 2 diabetes, and that may not be atherosclerotic related. So there's an atherosclerotic independent mechanism, which finally both of them together culminate into heart failure. Now, why this is so important to us, why we discuss so much about diabetes and cardiovascular disease, is because at the end of the day, the life expectancy is reduced. So this is a study which is showing that life expectancy is reduced by around 12 years in patients with type 2 diabetes if they have a previous cardiovascular disease. So around more than 135,000 patients deaths were occurred, and they were analyzed, and follow-up period was around, mean period was around 12.8 years, and 1.2 million participants were analyzed here. And the reduction in life expectancy associated with a combination of cardiometabolic multimorbidity. That's either the patient had a history of diabetes or stroke or previous MI. Now at the age of 60, if you calculate, then men with any of the two cardiometabolic conditions studied would on average have 12 years of reduced life expectancy. So on the right upper corner, you can see the graph. You can see the number of diabetes patients, age. We have taken the age of 60 years, but if the patients are younger, they will actually be losing more number of years. So the life expectancy reduction would be even higher at lower years. So if there is only diabetes, the life expectancy reduction is by 6 years. But a combination of diabetic plus either a previous myocardial infarction or a previous stroke, both will similarly reduce it by 12 years. So at the right down side, you can see this particular graph. So the initial at the lower part of the graph is a little complicated because a lot of things are there. But if you see the middle section of the graph, you will see two lines, one blue and one dark blue, they're both merging together. So these are the patients who have diabetes plus a previous history of either a stroke or a MI, and they both run very close to each other throughout the course. And if you take age 60, you will see the loss of years is around 12 years. If you take the age 40, you will see it is around 16 to 17 years. So at the age of 60, around 12 years of life expectancy is reduced if a patient have diabetes plus any one of the cardiovascular disease like a stroke or a MI. Now, this is a very recent study in the, published in around 2020 July. So here what they saw was the type 2 diabetes mellitus and the impact of heart failure and prognosis compared to other cardiovascular disease. So what they did was they tried to differentiate whether any one of the cardiovascular disease was conferring more risk in compared to the other. Now, this is from a Danish registry. So patients with new type 2 diabetes, again, is very important. So new type 2 diagnosis patients were identified in between the period of 1998 to 2015 through the Danish nationwide registers. At yearly landmark time points after type 2 diagnosis, type 2 DM diagnosis, they estimated the 5-year risk of death, 5-year risk ratios, and the decrease in lifespan within 5 years associated with the either development of heart failure, ischemic disease, stroke, peripheral arterial disease, and chronic kidney disease. Now, chronic kidney disease, again, causes a very high risk of CV event. We'll talk about that later. Now, a total of 153,403 patients were with newly diagnosed type 2 diabetes were followed for a median of 9.7 years. So that's a pretty long duration of follow-up. And what they found, the gist of the finding was that the heart failure development at any year since type 2 diagnosis was associated with the highest 5-year absolute and relative risk of death, and the decrease in lifespan within 5 years. So out of all this, heart failure, ischemic heart disease, stroke, peripheral artery disease, chronic kidney disease, heart failure had the highest 5-year absolute and relative, both absolute as well as relative risk of death and decrease in lifespan within the 5 years when compared with development of other cardiovascular or renal diagnosis. So heart failure, again, is very, very important when we look at cardiovascular disease among type 2 diabetes. Now, as I talked about that, chronic kidney disease also confers a great severe risk in patients with type 2 diabetes. So CKD remains an insufficiently addressed complication of type 2 diabetes, mainly because of decreased awareness at both the patient and the doctor level. And coexistence of CKD and type 2 DM are at markedly increased risk of mortality. So those patients who have both chronic kidney disease and type 2 diabetes, their risk of mortality or death is very high. And a subnormal EGFR emerged as a strong predictor of major CV event in diabetic patients, despite being normal albuminuria. Okay, so even if the normal albumin excretion is there, these patients are at a very high risk if the GFR starts falling down. And the presence of CKD associated with nearly 1.5-fold greater risk of major vascular events. So again, a very, very high risk of CV events in the presence of CKD. Now, here we will have a very brief look into the pathophysiologic mechanisms of heart failure in diabetes. So diabetes, we know, is accompanied by hyperglycemia, insulin resistance, and a concurrent hyperinsulinemic state. And this might, through the mechanisms of atherosclerotic cardiovascular disease, can give rise to ischemic cardiomyopathy, which might lead to heart failure. Diabetes is also very closely associated with hypertension, and through the mechanisms of hypertensive cardiomyopathy, again, can lead to heart failure. Now, there is another subset, what we call as diabetic cardiomyopathy, and they can also lead to heart failure. The various pathophysiologic mechanisms which contribute to diabetic cardiomyopathy includes the metabolic disturbances, where there is decreased glucose oxidation and increased free fatty acid, and obviously lipotoxicity. Now, disturbed cellular function is also there. There is impaired calcium handling and mitochondrial dysfunction, along with increased oxidative stress. And structural alterations are also seen. So structural alterations include cardiomyocyte hypertrophy and advanced glycosylated end product deposition. Cardiac autonomic neuropathy also is there in those patients who are suffering from diabetes for a very long period. And these patients are obviously at a very high risk of diabetic cardiomyopathy and other cardiac events. Neurohormonal activation, we know through the RAS pathway, it leads to, if it is overactivated, then it will lead to fibrosis and cardiomyocyte hypertrophy, and again leading to diabetic cardiomyopathy. So all these things are playing together. There's not in isolation. All the factors are contributing towards the heart failure. Now, if you look at the CV outcome trials for SGLT2 inhibitors in diabetes, we have come from the very first of EMPA-REG outcome trial for Empagliflozin in 2015. So this year it will be 5 years, and at EASD there will be a talk on the 5 years of data that we have gathered from EMPA-REG, post-EMPA-REG publication. And then there is the CANVAS study then happened then with canagliflozin, followed by DECLARE-TIMI 58 on dapagliflozin, and the latest in the addition is ortogliflozin CVOT that happened at 40 CV. So we have come a long way since the first EMPA-REG outcome trials were published, and we have a lot of data in our hand to analyze and give you a clear perspective on what's happening in this field of SGLT2 inhibitors. Now, coming to the EMPA-REG outcome data, we by now know that this was again a very interesting trial which actually changed the entire landscape of SGLT2 inhibitors and how we look at them. In 7,020 patients with type 2 diabetes and established cardiovascular disease, remember more than 99% of the patients in EMPA had established cardiovascular disease. Empagliflozin reduced the risk for 3-point MACE, CV death, or heart failure hospitalizations, and the composite of heart failure hospitalization or CV death significantly versus placebo. So the 3-point MACE was significantly reduced, so there was a superiority in there. It was both, first of all, it was tested for non-inferiority, and then it also tested positive for superiority. Then the CV death reduction of 38% was again significant. The all-cause mortality reduction of 32% again significant, and reduction in the heart failure hospitalizations, and there was also a decrease in the new onset or worsening nephropathy. So these were all exploratory secondary outcomes. All significant lowering happened in all these parameters. So, effect of empagliflozin on heart failure hospitalizations. So, we can clearly see that the difference in outcome was noted as early as 3 months after randomization. So, if definitely there was a benefit, and the benefit started extremely early in the treatment duration. So, you can see as early as 3 months, both the curves started diverging from each other, the placebo arm and the empagliflozin arm. And osmotic diuresis, effects on plasma volume and sodium retention with modulation of the cardiorenal axis had their own contributions. And cardiac remodeling, reductions in arterial stiffness, and the rate pressure product indicating diminished left ventricular afterload probably had also got a role to play in the reduction of hospitalization due to heart failure with those patients treated with empagliflozin in the EMPA-REG outcome trial. So the role of SGLT2 inhibitors in heart failure. In type 2 diabetes, SGLT2 inhibitors reduce the risk of hospitalization due to heart failure and the risk of renal events, benefits that are not seen with any other anti-hyperglycemic drugs. Risk of hospitalization due to heart failure was around 30 to 35% lower among patients who received the SGLT2 inhibitor treatment. And this benefit was most striking in the left ventricular ejection, in those patients who had a left ventricular ejection fraction of less than 30, or even less before the onset of the treatment. Cardiorenal benefits cannot be explained by SGLT2 inhibitors' ability to lower the blood glucose only, because similar effects have not been seen with other anti-diabetic drugs. Yes, there are exceptions to the GLP-1 receptor agonist, but those are injectable, and we'll be limiting our talk to oral drugs available in India. And SGLT2 inhibitor may slow the progression of cardiac and renal disease independent of the presence or absence of diabetes. So even in the absence of diabetes, SGLT2 inhibitor might be slowing the progression of cardiac and renal disease. So empagliflozin resulted, this is the EMPA Heart CardioLink 6 study, which showed the reverse cardiac remodeling. And empagliflozin resulted in early and significant reduction in the left ventricular mass regression, and suggesting that reverse cardiac remodeling may be a possible contributor to the cardioprotective effects of SGLT2 inhibitor. So in patients with type 2 diabetes and stable coronary artery disease, patients were evaluated, and it was seen that regression of left ventricular mass index was happening with empagliflozin over a 6-month period. And this is a proof of concept that beneficial effects of empagliflozin on left ventricular myocardial structure in patients with type 2 diabetes with stable coronary artery disease and even without the presence of heart failure. So if you look at the right-hand side lower bottom, you will see that the left ventricular mass index in the placebo arm was 62.2, and in the empagliflozin arm, it was 59.5 gram per meter square. And in the placebo arm, there was hardly any reduction around minus 0.01 gram per meter square, whereas in empagliflozin arm, the reduction was minus 2.6 gram per meter square. And if you see at higher baselines of LVMI, the reduction would be even higher. So here is a proof of concept that probably the beneficial effects of empagliflozin on left ventricular myocardial structure is also happening. So we will come to the Emperor-Reduced trial, as we have talked about. So Emperor-Reduced trial is a phase 3 randomized double-blind placebo-controlled trial. And the aim over here was to investigate the safety and efficacy of empagliflozin versus placebo on the top of guideline-directed medical therapy in patients with heart failure with the reduced ejection fraction. So this subset of patients had only reduced ejection fraction, and they were receiving all the standards of care, and they were having a left ventricular ejection fraction of less than 40 at least, and 3,730 patients were included in the study, and both were divided into the empagliflozin arm receiving a 10 milligram of empagliflozin plus standard of care, and in the other arm there was patients who received the placebo plus standard of care. And the median follow-up duration was around 16 months and maximum extending up to 34 months. Now, the endpoints, the composite primary endpoint. The primary endpoint was the composite of time to first event of adjudicated CV death or adjudicated hospitalization due to heart failure. So this was a composite primary endpoint. Now, 3,730 were randomly assigned to receive either empagliflozin or placebo, and the median duration I talked about was 16 months. And the baseline characteristics is again very important. Half the patient had diabetes and half the patient did not have any diabetes. So it is very important. We were evaluating a molecule which is classically known for treating diabetes, but has shown extremely good benefit regarding the hospitalization due to heart failure reduction. We're now being tested on patients who did not have diabetes. And 73% had a left ventricular ejection fraction of 30% or less, and that's a huge number. So 73% had an ejection fraction of less than 30, and 79% had an NT-proBNP level of at least 1,000 picogram per milliliter, and 48% had, almost 50% of the patient had a EGA for less than 60. And 20% of the patient were on angiotensin receptor, neprilysin receptor inhibitor, neprilysin inhibitor. So sacubitril valsartan combination was given in 20% of the population. Now, if we look at the results that came out, so SGLT2 inhibition with empagliflozin effective in heart failure with a reduced ejection fraction, whether the patient has a diabetes or without diabetes also. So primary endpoint was, I told you, a composite of cardiovascular death or hospitalization due to heart failure. And there was a 25% reduction in the composite outcome. And that is the primary endpoint. The secondary endpoint that was predetermined was the total, first secondary endpoint was total hospitalization, total heart failure, whether it was a first hospitalization due to heart failure or recurrent hospitalization due to heart failure. And there was a 30% significant risk reduction. So primary endpoint, 25% risk reduction, significant. Secondary endpoint, again, 30% reduction and significant. The second secondary endpoint was the slope of decline in glomerular filtration rate over time. And that was, again, 50% reduction in the renal events and also significant. So all the parameters that the study was designed to test had shown a significant reduction, which is statistically significant. This study was not empowered to look at the CV death, so that data is not there. But if you look, there will be a hazard ratio of 0.92. That means around 8% relative risk reduction happened with CV death, but significance cannot be calculated because the study was not powered to do that. So if you look at empagliflozin, so you will see empagliflozin prevented both serious heart failure and serious kidney failure events So if you just compare the baseline characteristics of this study with the DEPA heart failure, so you will see that the mean ejection fraction, left ventricular ejection fraction in the Emperor reduced trial was 27%, and in the DEPA heart failure trial, there was another trial with a similar kind of patient subset. So they had around mean ejection fraction of 31%. So it's a 27% versus 31%, meaning that this population of patients which were taken in for the Emperor reduced trial had a lower mean left ventricular ejection fraction. And if you look even at the pro BNP levels, okay, so NT pro BNP level, the median was around 1907 in the Emperor reduced trial, and it was around 1437 picogram per milliliter in DEPA heart failure. So this group of patients in the Emperor reduced trial actually had a more severe heart failure compared to DEPA heart failure study. And if you look, I told you the composite of cardiovascular death or hospitalization for heart failure, there was a relative risk reduction of 25%. It is being shown in the graph, and you can see the p-value being less than 0.0001, which signifies a very strong statistical significance. And the composite renal endpoint, again, there was a relative risk reduction of 50%, which is again significant. Adjusted mean changes from baseline in the estimated GFR. If you see, we have told that the rate of decline was of the GFR was a secondary endpoint in the Emperor reduced trial, and you can see the empagliflozin versus a placebo arm. Though the empagliflozin had initially shown a more sharp reduction in the eGFR, but over a period of time, if you see that the eGFR decline in the empagliflozin arm is far less than in the placebo arm. So eGFR declined by around minus 0.93 ml per liter in empagliflozin, and by minus 4.21 ml per minute in the placebo group. And the annual rate of decline in the estimated GFR is slower in the empagliflozin compared to placebo. So obviously it is showing its renoprotective effect in the longer duration. Maybe the benefit for hospitalization due to heart failure, which starts very early in the course of treatment, in around 3 months, the effect is very, very visible. The effect in the kidney may take a little bit more time, but it is definitely being protective towards the decline in GFR in the long term. Now, this is again a very, very latest study published in Lancet August 2020, 30th of August 2020. And it showed the effect of the combined risk of CV death or hospitalization due to heart failure was consistent with or without diabetes. So they did a meta-analysis of the DEPA HF study, that the heart failure study, and the Emperor reduced trial, as I talked about. So they did a meta-analysis of these two studies and the major outcome trials assessing the effect of SGLT2 inhibitor in hospitalization in heart failure with reduced ejection fraction with or without diabetes. And these trial expanded findings to patients with heart failure with reduced ejection fraction with and without diabetes who were receiving appropriate background treatment for heart failure. And what they did over here was they did it by many subpopulations. I have only given a glimpse of one particular part of the study. So here they have shown with diabetes and without diabetes, and both the groups, the benefit is there, and the interaction p-value is also non-significant. So there is no interaction in between them. And in the various subgroups, if you see, only except the race or the region, so probably the Asian race got a little bit more benefit. That was also seen in this study. Other than that, there were no other confounding factors which were actually influencing the data results. So it is very consistent across different subgroups and different populations. And specifically, even those patients who were receiving this sacubitril valsartan combination, even in those subgroup of patients, the Emperor reduced trial has shown it is equally beneficial. Now, in type 2 diabetes, risk reduction in CV death, I was talking about, because per se, the EMPEROR-reduced trial was not powered to look only at the CV death perspective in this to ascertain whether the values are significant or not. But if you look at the risk reduction in CV death in those with a prior MI, was around 41% risk reduction with empagliflozin and around 8% for dapagliflozin in the DEPA heart failure study. Now, safety, if you look at the safety, you will see that what we know about the risk, nothing else has come up as a safety concern. And yes, there is we know that if it is not properly used, there might be a risk of euglycemic decay with all SGLT2 inhibitors. So that problem is there. There is a higher chance of urinary tract infection and genital mycotic infection with SGLT2 use, inhibitor use. We know that for sure. And in the very elderly population, there will be patients will be at a little bit higher risk of volume depletion and hypertension, specifically when used along with diuretics. So there might be a little increased chance of that. But this study didn't show us anything else that we don't know about serious side effects. Related to cardiac disorder, you can see the empagliflozin arm had around 26.8% among the patients, and the placebo arm actually had 34%. So, and related to worsening of renal function, around 3.2% in the empagliflozin arm versus 5.1% in the placebo arm. So, really, no alarming safety concern was raised from the EMPEROR heart failure study, EMPEROR-reduced trial. So, EMPEROR-reduced trial has major implication for clinical practice, and there is no denying of this. The EMPEROR-reduced trial with empagliflozin, when considered together with the results from DEPA heart failure study with dapagliflozin, will have major impact on the management of patients with chronic heart failure and a reduced ejection fraction. So we are limiting this to a reduced ejection fraction because both the subset of patients that were tested in both the trials had heart failure with reduced ejection fraction. And it is very important to note that this benefit extends to those patients who has diabetes and even those patients who do not have diabetes. SGLT2 inhibitors have clinically important benefits, are given once daily. Again, the pill burden becomes less, so compliance increases with a once daily regime, require no dose adjustment, and are very well tolerated. Okay. Now there is compelling evidence that SGLT2 inhibitors should now be added to currently recommended treatment for this disease, for heart failure. So it will very soon become a standard of care. Now, after we have talked about the cardiovascular risk in type 2 diabetes patient, the prevalence of it, and then we have talked about the EMPEROR-reduced trial, and I've shown you that it is showing benefit in those patients with heart failure with reduced ejection fraction in whether you have diabetes or you don't have diabetes. Both the population got their benefit. And then there was also secondary outcome benefits was also there. And there was also a reduction not only in the hospitalization to heart failure, there was also reduction in serious renal events. And there was a 50% relative risk reduction in the decline of GFR, which was statistically significant. Coming from all the data we have got from the different CVOT trials and now all the specific trials like the kidney trial with canagliflozin credence, and then DEPA heart failure trial and DEPA CKD trial and the EMPEROR-reduced trial with empagliflozin. So the position of SGLT2 inhibitors in the treatment algorithm of type 2 diabetes is steadily rising since its advent. So the ADA 2020, they state that after you have given metformin and the proper lifestyle intervention has been tried, so if the patient is having either a CVD or CKD or heart failure and the GFR is tolerating it, then you should initiate these patients with SGLT2 inhibitors or a GLP receptor 1 agonist, which is unfortunately injectable, and we don't have the option of oral GLP receptor agonist yet. And mostly when there is a problem of the pipes, both can be used. But when there is a problem of the pump, the pumping mechanism, as evident by the heart failure data, so there SGLT2 has got definitely more role to play and more benefit to offer to the patient. And whenever you see that the patient has either a established cardiovascular disease or a CKD or a heart failure or a very high risk of heart failure, so immediately you should plan to see that whether this patient is a candidate for SGLT2 inhibitors or not. So that should always be kept in mind, and we should start evaluating the patient whether this patient can be given this molecule or not. If this patient is an eligible candidate, then it should be initiated in this subgroup of patient. And especially the combination of SGLT2 inhibitor and DPP4 inhibitor may be combined. Okay, so this combination medication is now available as a single pill tablet. So it is again very important in those patients who have a HbA1c of more than 1.5% above target. So the ADA recommends that combination medication can be directly started instead of a stepwise up titration of medication in those patients who have their HbA1c more than 1.5% above the target. Now, cardiovascular and renal outcomes data with SGLT2 plus DPP4 inhibitor combinations individually, if we look at that, we'll see the empagliflozin had a 3-point MACE superiority with CV death reduction statistically significant, hospitalization due to heart failure reduction again statistically significant, and renal benefits was a secondary exploratory analysis again significant. Linagliptin was neutral to the 3-point MACE, so there was no harm, it was cardiac safe. A CV death, again, it did not increase any risk to CV death or hospitalization due to heart failure. That was there with Saxa. The problem is there with Saxa. And renal, again, it showed no additional harm to the renal endpoints. Rather, there was a 14% regression of albuminuria, but we don't know whether the regression of albuminuria actually has any clinical long-term benefits in these patients. We don't know yet, but there was seen that there was a 14% regression in the albumin excretion in the patients receiving linagliptin. Now, dapagliflozin, if you see the 3-point MACE, again, it was non-inferior, but the superiority was not established. CV death, again, there was no significant reduction in CV death. Hospitalization due to heart failure was, though there was definite benefit even with dapagliflozin, and renal benefits again were there. And it is subsequently being established in the DAPA-CKD trial also. Saxagliptin, 3-point MACE, it was non-inferior, but CV death, again, it was neutral, but hospitalization due to heart failure actually it increased statistically significantly. It increased hospitalization due to heart failure. So not a very good choice in those patients who are either having a heart failure or a very high risk of having a heart failure. Renal, we cannot comment because not enough data is there because the population of patients who were in the Saxa had majority of them had a very good renal status, so we cannot comment on that. Orforgliflozin versus CV, again non-inferior in the primary endpoint. There was no statistical superiority that was achieved, and again the benefit with heart failure still persisted here, but no benefit to CV death. And renal endpoints, again, it was very neutral. There was nothing showing that there is a renal-protective effect with orforgliflozin. Sitagliptin, again, 3-point MACE, it is non-inferior, so it's cardiac safe. CV death, again, cardiac safety is there. There is no increased rate of hospitalization due to heart failure, again, very safe on that parameter. The renal, again, it has shown almost not much problem to the renal safety, but again, TECOS also had majority of those patients who had a very stable renal function. So from the TECOS study, much comment should not be made about the renal status. Now, among all these combinations that is available with us is the empagliflozin and linagliptin has got clear benefit over the other molecules that we have in our hand right at this moment, because 3-point MACE superiority is there, the cardiac death benefit, CV death benefit is there, the statistical significance, hospitalization due to heart failure, there is reduction, statistically significant reduction, and the renal endpoints in the exploratory analysis also has shown that there is a lessening in the nephropathy. And along with it, linagliptin being a very cardiac neutral medication. So a combination of both of them is a very good tool for us to manage diabetes, and maybe directly start them as a combination in those patients who are not achieving the target and their HbA1c is more than 1.5% of the target value. Now, this is the ADA recommendation that I talked about, but the ESC recommendation is the Cardiologic Society recommendation, European Society for Cardiology recommendation. If you see, they have said that if the patient is having ASCVD or a very high risk of ASCVD, then you should start SGLT2 even before metformin. So, okay, so drug-naive patients start with the SGLT2 inhibitors even before metformin. The ADA has yet not gone to that extreme. They have asked for a metformin initiation and physical therapy, and then if need be, you can start off with a SGLT2 inhibitor or a SGLT2 inhibitor plus a DPP4 inhibitor combination in those patients with high risk of ASCVD, heart failure, or CKD, provided their GFR tolerates and patient is eligible to receive it. Now, as I told you, this is just showing you that what I told is there. So, moreover, since the absolute effectiveness of most oral medication rarely exceeds 1%, initial combination therapy should be considered in patients presenting with HbA1c level of more than 1%, 1.5% above target. So, if the HbA1c is more than 1.5% above your target, then it is better to start off with a combination medication. The principle being hit early and hit hard. So there is definitely some complementary reaction which is actually benefiting the patients who are given both a DPP4 inhibitor and SGLT2 inhibitor. And insulin dependent mechanism is working through the DPP4. We know that it works through the insulin dependent mechanism. SGLT2 inhibitor, the mechanism is completely insulin independent. It works through the kidney. So completely different set of pathophysiology being taken care of by both the molecules, and decrease in glucagon and endogenous glucose production, whereas SGLT2 inhibitors actually causes a rise in glucagon and endogenous glucose production. So when SGLT2 inhibitors are combined with DPP4 inhibitors, so they take care of each other. DPP4 inhibitor is weight neutral, so it does not lead to any weight gain or it does not cause weight loss. But SGLT2 inhibitor has got a decreased weight benefit. So there is a weight loss benefit associated with SGLT2 inhibitors, and there is also a reduction in the systolic as well as diastolic blood pressure with SGLT2 inhibitors. Now, DPP4 inhibitors causes GLP-1 levels to rise. SGLT2 inhibitors also causes GLP-1 levels to rise. There is a decrease in the fasting and the postprandial blood sugar in both the molecules. And very important is that they have got minimal or no hypoglycemic risk. So again, a combination is very important because there is extremely low risk of hypoglycemia. So again, a very important armamentarium, important armamentarium in our hands at the moment. And if you look at HbA1c baseline of 8, which is very modest elevation, even at that HbA1c with the combination medication, you can clearly see the reduction in HbA1c has been more than 1%. Okay, so higher HbA1c, more is the reduction. So even at a very modest elevation of 8% HbA1c, we can see a more than 1% reduction in HbA1c in those patients who were offered the empagliflozin and linagliptin combination. And whether the patient was drug naive or the patient received metformin in the background, it was independent of that. It had a persistent decrease in HbA1c over more than 1% across this HbA1c baseline. And if you see the durability, so not only the achievement that happens with the fixed dose combination, there is a very early achievement and of the glycemic control, and the glycemic control is durable. So if you look at this study where both monotherapy and the fixed dose combination were used for both linagliptin and empagliflozin, you can see that the this fixed dose combination was able to achieve the target earliest, and they were the only ones who actually were able to maintain it for a very long duration of time. So very early achievement, and that means very good efficacy. And not only it is efficacious, it is making it happen early, and it is making it durable. So for a very long duration of time, the HbA1c was maintained below 7. DPP4 inhibitors moderate the risk of genitourinary tract infection associated with SGLT2 inhibitors. So when I was talking about the possible adverse events that happen, yes, genitourinary tract infections are a concern, and we need to be alert about the genitourinary tract infection. What was strikingly important is that this is a meta-analysis and of 5 RCTs. So you can see Rosenstock, Mathey, DeFranco, Tina Holmes, and Levin. They all did the RCTs, and it was a meta-analysis of the RCT, and it clearly showed that genital tract infection actually decreased when DPP4 inhibitors were added along with the SGLT2 inhibitors. Okay, so SGLT2 inhibitor alone may have a higher risk than SGLT2 inhibitor plus a DPP4 inhibitor combination. The reason we don't know what is happening, why it is happening, and maybe there is some immunomodulatory benefit that is being achieved by using a DPP4 inhibitor along with the SGLT2 inhibitor. And if you see that better safety outcome with simultaneous SGLT2 and DPP4 inhibitor fixed dose combination as compared to sequential addition of SGLT2 inhibitor to DPP4 inhibitor. So if you are adding sequentially versus you are adding it simultaneously, so if you look at this data, you will see that if you add it simultaneously, the risk of genital tract infection is actually lower. So the benefit with empagliflozin and linagliptin fixed dose combination in patients, you can see the robust HbA1c reduction with extremely low risk of hypoglycemia, 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents, early achievement of the glycemic goal as I talked about, and with a very good durability. Proven CV and heart failure evidence with empagliflozin linagliptin combination. I told you linagliptin is absolutely cardiac neutral drug, and empagliflozin actually offers, not only it is safe, but it offers benefits in patients. So there was a reduction in the 3-point MACE by 14%, and then cardiac mortality, CV death was reduced by 38%. All-cause mortality reduction was 32%, all being statistically significant. And proven renal evidence with empagliflozin and linagliptin combination. Again, the EMPA kidney study will come, and then will give us more robust data regarding the renal protection. But through all the studies that we have seen that there is definite benefit. Here also in the Emperor Reduced trial, we have seen as a secondary endpoint, the decline in GFR was substantially reduced by empagliflozin. And also in those patients who didn't have a diabetes, along with those patients who had a diabetes. And then finally, the convenience of oral dosing of once daily. So this is also very important. Firstly, it is oral, and then the dosing is once daily. So it reduces a lot of pill burden which diabetic patients may accumulate over the years, and then they also have dyslipidemia and hypertension and other comorbidities associated. So if we can reduce the pill burden, overall the medication compliance is improved. Thank you. I will take any questions which is there.
Sir, right now there are no questions. But, can we wait for a few minutes if attendees have any queries so they can ask?
Okay.
Okay, sir. I guess there are no any further questions. So can we conclude the session with your permission?
Yeah.
Yes, sir. I think there are no any further questions. So can we conclude the session with your permission?
Yes. 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 Sure. Sure. Thank you.
Thank you, sir. On behalf of organizer, thank you for your insightful and educative talk, sir.
Thank you.
Thank you all the attendees for patient listening. I'm ending the session now. Thank you so much, sir. Thank you. From now